Sir? Sir?
പറഞ്ഞോ.
Sir, നമുക്ക് തുടങ്ങിയാലോ?
5 മിനിറ്റ് നോക്കാം. ഇപ്പൊ എത്ര ഷാർപ്പ് 7:32 എത്രയായ?
7:37 കഴിഞ്ഞു.
ഒരു 7:35 വരെ വെയിറ്റ് ചെയ്യാം.
എന്നാ ശരി.
ഓക്കെ സാർ.
ഇപ്പൊ RIOയിൽ ഇപ്പൊ ആരാ ഇത് കോർഡിനേറ്റ് ചെയ്യണേ? മിനിയാണോ അതോ?
മിനി മാഡം കാണാറുണ്ട്. പിന്നെ അവിടുന്ന് മറ്റേ സൂമിന്റെ ഒക്കെ ചെയ്യുന്നത് അബി എന്ന് പറഞ്ഞിട്ട് അവിടുത്തെ
ഇവിടുത്തെ PG റെപ്രസെന്റേറ്റീവ് ഒക്കെ ആരാണ്?
അതെനിക്കറിയില്ല സാർ. മിനി മാഡത്തിനാ ഞാൻ കോണ്ടാക്ട് ചെയ്യാറ് ആവശ്യത്തിന്. എന്തെങ്കിലും ഇത് വരുമ്പോഴേ മിനി മാഡത്തിനോടാ ചോദിക്കാറ്.
മിനി അവിടെ ഈ പറഞ്ഞ പോലെ അവിടുത്തെ PGസിനെ അറിയിക്കാന് ഉള്ള റൂട്ട് മിനി തന്നെ അല്ലേ?
മിനി മാഡത്തെ അപ്പൊ മാഡം അവിടെ പഠിക്കുന്നുണ്ടല്ലോ. അപ്പൊ പിന്നെ ഗൂഗിൾ ഫോം നമ്മള് RIO അലൂമിനിയുടെ ഇതിൽ ഇടുന്നുണ്ടല്ലോ.
അതെ, അവരറിയുന്നുണ്ടായിരിക്കും.
അപ്പൊ അവരറിയാതിരിക്കില്ലല്ലോ.
നമുക്കൊരു ഷാർപ്പ് 7:35 ആകുമ്പോ സ്റ്റാർട്ട് ചെയ്യാം.
ഓക്കെ സാർ.
തുടങ്ങാം. ഇപ്പൊ എലിസബത്ത് 2 വാക്ക് പറഞ്ഞ് തുടങ്ങിക്കോ.
Good evening, everyone. Good evening, sir, Dr. Matthews. Today we are going to have a case presentation by Dr. Matthew from Travancore Medical College and chaired by Dr. Sahasranaman. So I welcome you all for the presentation. Can we start, sir?
Yes, we'll start. Matthew, you can start your presentation.
Yes, sir. Good evening, all. First of all, I'd like to thank everyone for this opportunity. Presenting the case of presenting the case of Mr. Cyril Kumar, who is a 51-year-old male who resides in Kollam, who visited our OPD on 31/8/2023 with complaints of watering followed by pain and diminution of vision in left eye since 2 days. He again complains of swelling and discharge from left eye since 1 day. History of presenting illness. Patient was apparently normal 2 days back when he noticed excessive watering from the left eye, sudden in onset in the morning. This was followed by pain and redness in the left eye, stabbing type, progressive, with no aggravating or relieving factors. It was associated with sudden onset of diminution of vision in left eye, with left-sided headache and vomiting. Patient had gone to a local eye hospital. He was told to have elevated eye pressure in the left eye and was given medications for the same. Following which the pain slightly reduced, but there was no improvement in vision. Patient was referred to our hospital then. He was advised admission, but the patient was not willing for the same. He continued the same medications that were given to him. Next day morning, patient noticed a swelling over the left eye associated with yellow colored discharge. Patient was unable to open his eye and pain had also increased. The patient gives history of a minor procedure in the neck, which was done in relation to hemodialysis the previous day. No history of any ocular trauma in both eyes. No history of similar episodes in the past. No history of similar complaints in the other eye. No history of any ocular surgeries. No history of any flashes or floaters. And no history of any fever. There were no history of any major surgeries done. Past history. Patient is a known case of type 2 diabetes mellitus since 20 years on insulin with good glycemic control. Patient is a known case of hypertension since 18 years and is under control. Patient is a known case of chronic kidney disease on hemodialysis, which was done twice weekly since the last 1.5 months. The last hemodialysis was done 3 days back. Family history. No history of glaucoma in the family. Personal history. Diet is mixed. Appetite is good. Sleep is adequate. Bowel and bladder is within normal limits. Hello.
Yes, you are audible.
Okay, madam. Where sound get la to I आपको stuck है बोलना. General physical examination. Patient is conscious, cooperative, oriented to time, place, and person, moderately built and nourished. Paathsaala was present. Bilateral pitting type pedal edema was present. No icterus, cyanosis, clubbing, generalized lymphadenopathy. On head to foot examination, there was no visible pus or black eschar in the nasal cavity. No dental caries were seen. Vitals, pulse of 88 beats per minute, regular rhythm, good volume, normal character, no radio-radial or radio-femoral delay. BP of 130/80 mmHg in the right arm supine position, respiratory rate of 20 per minute, abdominal thoracic type. Patient was febrile at the time of examination. Systemic examination, cardiovascular system, S1, S2 heard, no murmur. Respiratory system, normal vesicular breath sounds, no added sounds. Per abdomen, soft, non-tender, no organomegaly. CNS examination, no focal neurological deficits. This is the patient's photo. Now coming to ocular examination. The head posture is normal. There is left parietal area showing a diffuse edema with complete ptosis in the left eye. There is axial proptosis in this left eye seen. There was no nystagmus. Extraocular movements in the right eye was full in all directions. In the left eye, there was -2 restriction in all directions of gaze. Proptosis examination of the left eye. On inspection, periorbital fullness was present with axial proptosis. Thick yellow mucopurulent discharge was seen. No visible pulsations noted. Skin appears normal. On palpation, orbital margins were intact. Tenderness was present. Local rise of temperature was present. No pulsations or thrill. Finger insinuation test was not done due to the pain. There were no enlarged regional lymph nodes. Hertel's exophthalmometer also was not done because of pain. Visual acuity, right eye unaided 618 with BCV of 612. In left eye, perception of light is present but with inaccurate projection in the temporal and nasal field. Near vision, in the right eye, N6 with plus 2 diopter spherical lens. In the left eye could not be assessed. Color vision was normal in the right eye, left eye could not be assessed. Field by confrontation was normal in the right eye, in the left eye it could not be assessed. Examination of the affected eye, that is the left eye. Periorbital area, there is fullness seen. Eyeball, there is axial proptosis noted. Eyelid and adnexa, there is diffuse upper lid edema. Skin over the upper lid appears normal. Tenderness was present. Mucopurulent discharge was seen. And matting of lids was seen. Lacrimal apparatus was normal. Regurgitation and pressure over the lacrimal sac was negative. Conjunctiva showed diffuse conjunctival congestion, circumcorneal congestion, chemosis, and mucopurulent discharge. Scleral details could not be seen because it was obscured by chemosis and congestion. Cornea, there was diffuse epithelial edema with stromal edema. Dense brown pigments were present uniformly over the endothelium. Further details were hazily seen. This is a picture of the cornea. Anterior chamber appears flat with iridocorneal contact at periphery. No hypopyon seen. Gonioscopy was not done. Iris, pupil, lens details could not be appreciated. Intraocular pressure by applanation tonometry was 54 millimeters of mercury. Fundus examination on distant direct ophthalmoscopy, no red glow was seen. There was no yellow reflex. Slit lamp with 90D and indirect ophthalmoscope with 20D, there was no view obtained. Examination of the right eye. Periorbital area, eyeball, eyelid and adnexa, lacrimal apparatus, conjunctiva, sclera were normal. Cornea was clear with no capies of pigments on the endothelium. Anterior chamber showed a Van Herrick's grade 3 with no cells of flare. Gonioscopy, Schaffer grade 4 with no neovascularization on the angle structures. Iris was normal with no neovascularization of the iris. Pupil was 3 mm round. Direct light reflex was brisk. Consensual light reflex was absent. Lens showed early cortical cataract changes. Intraocular pressure by applanation tonometry was 13 millimeters of mercury. On distant direct ophthalmoscopy, red glow was present. On slit lamp with 90 diopter lens, media was slightly hazy due to lenticular opacity. A cup disc ratio of 0.3 with well-defined margins. Vertically oval disc, horizontally oval cup. Neuroretinal rim was pink. ISNT rule was maintained. This is a fundus pic. Vessels arise from the center of the disc, branching dichotomously with an AV ratio of 1:3. There was generalized arteriolar narrowing. Venous tortuosity was present. Tributaries of the superior and inferior temporal arteries were sclerosed from arcade to the periphery. There were few pinhead-shaped red lesions continuous with the vessels seen in the inferotemporal quadrant. In the posterior pole, suggestive of microaneurysm. In the macula, a shiny reflex of 2 disc diopter at the macula, suggestive of an epiretinal membrane. Foveal reflex was dull. On indirect ophthalmoscopy with 20 diopter lens, above findings were confirmed and periphery showed no neovascularization. No exudates were also seen. Summary. A 51-year-old male who is a known case of type 2 diabetes mellitus, hypertension, chronic kidney disease on hemodialysis, who came with complaints of watering followed by sudden painful diminution of vision in left eye since 2 days, which is followed by swelling and discharge from the same eye the next day. On general physical examination, pallor and bilateral pitting pedal edema were present. On ocular examination, he had axial proptosis of left eye with tenderness on palpation and restricted extraocular movements. His best corrected visual acuity was 612 in the right eye and perception of light with inaccurate projection in the left eye. Local examination of the left eye showed periorbital fullness, diffuse lid edema, axial proptosis with tenderness and local rise of temperature. Diffuse, hello, ma'am. Local rise of temperature, diffuse conjunctival congestion, chemosis, and profuse mucopurulent discharge. Cornea showed diffuse edema with pigments on the endothelium. Anterior chamber was flat with iridocorneal contact at the periphery. Intraocular pressure was 54 millimeters of mercury on applanation tonometry. Other details could not be appreciated in the left eye due to the anterior segment pathology. Right eye anterior segment examination was within normal limits. Gonoscopy of the right eye showed open angles with intraocular pressure of 13 mercury on applanation tonometry. Right eye dilated fundus examination showed grade 3 hypertensive retinopathy with mild non-proliferative diabetic retinopathy with an epiretinal membrane at the macula. Provisional diagnosis. In left eye, secondary angle closure glaucoma with panophthalmitis. In the right eye, cortical cataract with grade 3 hypertensive and mild non-proliferative diabetic retinopathy with epiretinal membrane at the macula. Type 2 diabetes mellitus, hypertension, chronic kidney disease on hemodialysis.
So we'll stop here. Okay. So,
Okay, sir.
So will you go to that's it. The summary slide. You can go back to the summary. So
Okay,
those
sir.
who have come in late, no. So those who have joined late. So we have got an 51-year-old male with 20 years of diabetes, hypertension, CKD on dialysis for the last 1.5 months, with sudden onset of painful defective vision to the extent of PL, with an painful axial proptosis, with restricted ocular movements, with PL and inaccurate projection, with chemosis, diffuse corneal edema, which obscures the further details of the anterior segment, a flat TP, and the other eye showing features of mild NPDR and grade 3 hypertensive retinopathy with an ERM. So that's the summary. Okay. And you have your provisional diagnosis was, go to the next slide. Next. Okay. So here got an panophthalmitis with an secondary angle closure glaucoma. Okay. So why do you say it's an panophthalmitis? But what's your differential diagnosis? Is there any differential diagnosis?
Differential diagnosis, left eye orbital cell. It would be left eye orbital cellitis, left eye
Whenever
endogenous.
we talk about a DD panophthalmitis, you can say endophthalmitis.
Endophthalmitis, endogenous endophthalmitis, orbital cellitis. It could be an orbital abscess.
Okay. So and if your first diagnosis is panophthalmitis left eye, what makes you diagnose a panophthalmitis in this patient? What are the features?
So
To
first,
say a panophthalmitis.
There was initially the patient presented with there was initially the patient had watering redness followed by discharge and then swelling also on the next day. So initially there was this corneal edema with proptosis and pain proptosis, corneal edema, and on fundus examination we did not get the red glow or the yellow glow, and there was EOM restriction. So all this led to panophthalmitis with severe pain also, which increased.
So again, I think probably you can put it like the clinical features of an severe acute intraocular purulent infection of the left eye with periocular involvement in the form of chemosis, restricted ocular movement of hyperacute onset. Right. So
Yes.
So essentially, when we differentiate between an panophthalmitis and endophthalmitis, what are the differences that we say? Endophthalmitis is one which is confined to the globe with the
Yes.
codes spared, so the ocular
Sterile
movements
spread.
will not be involved. So here we have got an clinical feature suggestive of a very severe virulent intraocular infection of all the intraocular contents, along with periocular involvement also with the codes involved, with the surrounding tissue involved, periocular tissue is involved, ocular. So that's why you say it's an panophthalmitis. So why do you say it's in secondary angle closure glaucoma? Why did that diagnosis come in? Why?
Angle closure, because initially on the first day when the patient presented, it was
Well, one thing, there's an angle closure. The other
yes,
eye
sir.
remaining open. The other eye.
Yes, sir.
So why you say it's in second angle closure is because secondary primary comes in later. Right eye findings are suggestive of an open angle. By
Open angle. So
Van Herrick's, your
yes,
Schaffers, all. So it's an open angle. So you have got an angle closure glaucoma in one eye.
open
With
angle and open.
added features. So probably you think it's in case of secondary angle closure glaucoma. Okay. So the other eye findings are of that of an wide open angle.
Yes.
So this patient with panophthalmitis, diabetes, and hypertension, secondary. So usually